Let's get started with, where did your curiosity with nutrition begin? Is this something that you've always been interested in, or was this something that kind of grew as you got older?
Yeah, good question. So actually, it was not something I was always interested in. I actually grew up in a household where healthy eating was kind of the norm. I didn't really think too much about it, but I struggled with several eating disorders, even longer history of disordered eating. And actually, I ended up in a hospital and talking to a dietitian, and it was not a great experience. It was very cookie cutter. Didn't feel like I was really being listened to or seen, just kind of in and out, eat more. And I just thought, whoa, that was like, screw this. But, and so it just kind of left my conscious mind. And then when I went into college, I studied food systems and sustainability and really grew to love food in that broader context of sustainability and politics and social justice. And then my relationship with food started to heal. And then I went into public health after I graduated, and then just grew deeper and deeper in love with the field of nutrition.
When did you notice that you had like an issue with like eating? I guess, growing up, I'm sure it's difficult to even like diagnose something like that yourself, but when did you notice that maybe something was wrong?
Looking back, very early on, probably around 8 years old.
Oh, wow. And then did your parents kind of help you out, or was this something that you had to seek out care for yourself? Or I guess what happened?
Yeah, it's really tough for my parents. I think they tried to help as much as they could. And when they actually brought me into a hospital, I was maybe 5 pounds away from being at a weight where I should have been hospitalized. And so I got to walk out of that experience. And so I think they were kind of at a loss, and they had never really quite knew what to do. I'd been, I don't remember if at that time I was seeing a therapist, possible. But yeah, it was definitely a struggle for them. And it took me a long time to be ready to kind of heal that relationship.
Well, I'm sure your relationship with food has changed significantly from there to
Mhm.
now. And I guess like becoming a registered dietitian, how does it change the way you look at food?
Yeah, it's a good question, because I feel like a lot of that transformation happened before I became a dietitian and kind of facilitated my entry into the field. But I will say that when I first became a dietitian, not all of my disordered eating was totally absent. And so having that experience, and then also as a dietitian being diagnosed with celiac disease, which was really tough, and then working with hundreds of people with their own relationships and experiences and barriers and challenges, and more importantly, their chronic diseases, and that kind of culmination of my experiences and their experiences really helped to emphasize the importance of taking agency over the narrative that we create around food and how we relate to it. So that
Mhm.
was really big for me. And then also just having the space to really confront it while helping other people really helped me as well. And since nutrition is my job, I work with a lot of different people, not just diabetes, all kinds of reasons for nutrition consults. So I'm always staying up to date, which means I'm constantly learning. And I love that. So my understanding of nutrition is constantly evolving. And again, not so much that that necessarily changes the fundamental way that I see food, because that was pretty much well established before I entered the field, but it definitely brings a lot of depth um, in terms of how I see food, how I relate to it, and how I interact with other people and help them in their journeys.
I was going to say your skill for empathy, maybe, I don't know if it was there before, but I know when I started as a physical therapist, relating to patients was much easier because I had an episode of low back pain. And I'm sure having gone through with what you've gone through, it's like, you're like, listen, I've been there, or at least you can understand maybe some of the emotional pitfalls that you may run into when you're dealing with issues related to your diet.
Yeah, absolutely. I mean, that empathy for sure, having gone through those experiences, and even if it's not a total parallel, because everybody kind of has their own experience, especially when it comes to diet and chronic disease, but just being able to acknowledge, we all come with our own set of baggage and struggles and goals and values. So for sure, it's been helpful.
Well, I'm so happy they kind of came out on the other side with so much, wisdom and, almost like use the bad for good, so to speak. And you made the best of it. And, we started talking about food, I guess, simplest form. How do you describe what food is? Because I think everyone has their own interpretation and relationship with it. And so I guess in the most basic sense, what would you describe food is? Is it a nutrient source? Is it a coping mechanism? Like, how do you describe it?
Yeah, and that goes back to that narrative, right? It can be whatever we make it.
Mm-hmm.
And so that's where we can take power and decide, what should it be to me? But at its most basic sense. And I think this is a really interesting question because, like you said, we can think of it in various different ways. We can use it in different ways. And usually when we say the word food, it's kind of attached to some kind of adjective or modifier like junk food or nutrient dense food or clean food. But if you take all that away and kind of think at its basic level, at an objective level, it is, I think, any substance that we consume, digest, absorb, and utilize in order to sustain life and function. So it's super broad.
We're talking about food and how you can describe it. One way that I know a lot of people kind of think of food is like in the terms of like macros or like calories. And so what are the different macros? So that way maybe everyone understands like what they are and how are each of these processed in a different way in the body?
Gotcha. Yeah. So on that kind of level, it is useful to kind of get a basic understanding of those different macros. So other than water, the three major macronutrients, which means we need them in large amounts in order to sustain life and function, would be carbohydrates, fats, and proteins. And we could definitely go down a rabbit hole with each of these, make them each their own kind of podcast episode. So I'm going to try and be as brief as possible. They all kind of like go through the same GI like tract process, but especially when we think of something like blood sugar, which we'll talk about more today, I can kind of like go deeper into each of the macronutrients and blood sugars, if that would be helpful.
I think one way maybe we could start off is talking about like, is each calorie the same? So is like one carbohydrate synonymous with 1 gram of fat, or is 1 gram of fat equal to 1 gram of like protein?
Gotcha. Yeah, you're taking me way down to the basics.
Yeah.
And actually 1 gram of carb isn't even equal to 1 gram of another carb.
Right.
So we can keep going down that. And the answer is no. I mean, 1 calorie is not another calorie. We don't eat calories. We don't eat macros. We eat food. So there's going to be a lot of variations, but at a metabolic level, carbohydrates, fats, and proteins kind of all have different influences from things like lipid production or insulin resistance or blood sugars. And yes, they go through different digestive processes. I'm trying to think very, very fundamental, but 1 gram of carbohydrate is about 4 calories. 1 gram of protein is about 4 calories. 1 gram of fat is about 9 calories. And this is just an estimate. It's not exact. And then from one food to another, it's going to kind of vary.
Right. And I think the most important part, and, like I'm getting into the weeds a little bit just so that way everyone can kind of get a fundamental understanding of like how low this can go in regards to understanding what food exactly is. And there's a lot of nuances, and that's why I feel like the field of like nutrition can be very confusing because everyone's got their own opinion, or maybe they read something and they're like, this is like gospel or the Bible, or so to speak. But overall, each macro does have a certain nutrient value, and the body can process them in different ways. And one of those ways that the body uptakes that or processes it is through the use of insulin. And so since you do have so much expertise within diabetes education, I guess, what is insulin and where does it come from?
Yeah, definitely important to understand for diabetes or really just in general. But insulin is a hormone that's produced in the pancreas. And it's a long-term satiety hormone, which means that there's always some amount of insulin floating around in circulation at all times, just like there's some amount of glucose. But insulin is secreted by the pancreas in response to a meal, particularly meals with carbohydrates, but not just carbohydrates. I can go into that a little bit more later if that comes up. But that's really important. That insulin response allows the cellular uptake of glucose from the blood. So it helps to manage our blood sugar levels.
And what makes it so that you have diabetes? Like, what is the relationship between like the actual official diagnosis of diabetes and like its relationship to insulin? Because I think people hear diabetes and they're like, well, it has to do with insulin. I'm like low in insulin, or am I high? I have too much insulin. I guess, which is it?
Yeah. It depends on the type of diabetes. The two main types would be type 1 and type 2 diabetes. Type 1 diabetes is autoimmune. So there is, with that autoimmune component, the beta cells of the pancreas are being attacked by the body's own immune system. And so there's an absolute insulin deficiency. So insulin levels are low and the body cannot process sugars. They rise. Puts people in danger of diabetic ketoacidosis, etc. So type 2 diabetes is different in that there's no autoimmune component. And the natural history of type 2 diabetes is such that you have a normal insulin level and a normal insulin resistance in the beginning. And then over time, insulin resistance starts to increase, and then tracking that would be insulin release. So insulin resistance goes up while insulin secretion increases as well. So for a while, insulin's going up, insulin resistance going up, but blood sugars remain stable because the body's able to compensate for that increase in insulin resistance with extra insulin. And at a certain point, there's going to be some beta cell dysfunction. So maybe the pancreas starts to not keep up so much. And then you start to see an increase in your blood sugars. And at a certain point, you get full-blown diabetes diagnosis.
Now, is it direct? I mean, insulin's obviously related, in building insulin sensitivity. Is it related to just eating more, or is it just like eating certain foods, like, or maybe a little bit of both?
Yeah, a little bit of both. For sure, excess like added sugars and refined carbohydrates, high fat diets or standard American diet that is kind of rich in all of those foods that I just mentioned, but also just eating excessive calories and around the clock. So all of that plays a role in promoting insulin resistance.
So eating around the clock is not necessarily a good thing, or I guess it just like situationally different, or?
No, definitely not a good thing. So, I mean, historically, evolutionarily speaking, we weren't eating for 15 hours in a day. And I work with a lot of patients who just kind of generally eat maybe 15 or more hours throughout the day, eat late into the night. And we definitely have plenty of data showing that that's associated with more risk of chronic diseases, including diabetes. But for one, our insulin resistance increases later in the day. So it's actually, we're more efficient metabolically speaking. We have better insulin sensitivity earlier in the day. So one, just eating later at night is part of it, but two, just constantly eating, always being in that postprandial stage, constantly triggering insulin release from the pancreas. That's going to be part of that pathogenesis into diabetes.
So this diabetes. Right. And so this idea of like having like, I guess 5 to 6 small meals throughout the day is not really ideal then, right?
Yeah, that's interesting. So if you're having 5 or 6 small meals and the answer is it depends. And I feel like with a lot of nutrition, the answer is going to be it depends.
For sure.
Because if you're eating meals that are primarily starch with inadequate protein, not a whole lot of vegetables, a lot of ultra processed foods, yeah, 6 small meals per day isn't exactly going to do you any favors. You're constantly in that postprandial phase, but also those are the types of foods that are going to trigger more lipotoxicity, inflammation, oxidative stress, insulin resistance. Whereas if you're having 6 small like well-balanced meals, that could be fine. And then that goes back to like all this nutrition kind of debate and controversy, I think, is in part to not recognizing the unique kind of fingerprint that each of us have when it comes to our genetics, our epigenetics, our ancestral or like family history. All of these factors, our microbiome, so that 6 small meals a day might work great for one person and be just not a great strategy for someone else. So unfortunately, or maybe fortunately, there's just a lot of gray area in answering these questions. So
I think and the more I dive into just like health and wellness and everything, I feel like the more we use broad brushstrokes, the worse things get, right? Like the scale of BMI is probably like one of the worst things to reference if you're trying to look at like individuals. Like I'm technically overweight, like and it's just, it kind of, when we start using these like hard, fast rules for things such as nutrition or exercise, it's just a lot of the time the answer is like, well, it depends really. Is your life conducive to doing 5-6 meals a day, or do you feel like crap all day because you're eating 6 times a day? So I'm sure you're dealing with management of that all the time.
Yep, absolutely. I get a lot of those black and white questions. How many calories should I eat? How many meals is right? Is this food good or bad? And a lot of the answers are, well, it depends, or, oh, tell me about your experience first before I answer that question.
And are you getting a pretty solid history in regards to just trying to understand the person before you start making recommendations?
Oh yeah, absolutely. At least 30 minutes for assessment of diet, lifestyle, family history, medical history, weight history, although our clinic is starting to move away from that even and kind of focus on these other risk factors. But yeah, it's really important to understand the context of a full human being before making recommendations.
And one thing, with diabetes, it's always, I think we always think of diseases as either you have it or you don't. But there's this thing that you said earlier was like called prediabetes, right? And so I guess, what is prediabetes, and when is it okay for you to say that you have this or whatever?
Yep. So prediabetes is defined by the American Diabetes Association as a hemoglobin A1C of 5.7 to 6.4%, or a 2-hour postprandial blood glucose of 140 to 199, and that's after 75 grams of a glucose challenge, a drink containing glucose, or a fasting blood sugar between 100 and 125. And in order to be able to say officially you have diabetes, you need at least 2 abnormal tests. So either in the same sample, like an A1C plus a fasting, or 2 from separate test samples.
Maybe just explain what those tests are for people who aren't sure what those are.
Yeah, exactly. I was just thinking that as well.
Yeah.
So the hemoglobin A1C is a 2 to 3 month average of blood sugar control. So when there's glucose in the blood, and there's always some glucose in the blood, again, some of those are going to attach to hemoglobin, and that's going to form glycated hemoglobin, right? So we're measuring the percentage of glycation on hemoglobin. So normally, like a normal A1C is below 5.7%, and then prediabetes is that 5.7 to 6.4%, and then diabetes is diagnosed at 6.5%. And honestly, hemoglobin is not the most sensitive test, but it's very easy to do. You don't need to be fasting. It does kind of break down in different ethnic groups. So it's not always the most accurate. So I like having that plus a fasting glucose instead of just looking at an A1C. Does that one make sense?
Yeah. And I was going to say also, it's got to vary differently between men and women as well, because like men have more blood in their body than women. So it's got, or is it standardized based off of like body weight and things like that?
Oh, that's really interesting. I actually don't know if there's any difference between men and women. I've never seen anything about that, but you bring up an interesting point, because we know that medicine and science in general is just more biased towards men.
Hmm.
So that's really interesting. And I just don't know. I haven't heard of that one.
Because you'd think that like if you're using the same levels for a man to a woman, you know, a woman may have already had diabetes for a longer time if they already need to like reach the level of what a man has in regards to maybe like overall blood in their body or like percentage of like certain things, so to speak. Because if the concentration is the same in, well, if the value is the same in a woman but the concentration is like way higher, it's like, okay, well, you've been pre-diabetic for the past like year, we could have done something beforehand.
That's interesting. Yeah. I'll have to look into that one more. My understanding, and this might not be right, is that it's kind of based off of like the hemoglobin itself and not like the wealth
Oh,
of
okay.
red blood cells. Um, but possibly we do know that anything affecting red blood cell turnover can make A1C less accurate.
Gotcha. Well, overall, I guess is being pre-diabetic like reversible? Is this something that you can prevent and manage?
Yes, absolutely. Prediabetes is reversible for most people. And again, it kind of depends on where you are in that natural history of diabetes. And so, more likely to reverse it, or I shouldn't say more likely to reverse it, but at a higher A1C, even within the prediabetes range, people are more likely to then go on and develop diabetes within the next 5 years. So, anywhere along that spectrum, the lower you are, the more primed you are to really reverse it. But yes, anybody most of the time can reverse it with proper changes in eating, in lifestyle, like exercise, sleep, stress, and for some people, medication. And mainly when it comes to prevention of diabetes, we're going to think of the National Diabetes Prevention Program. It was a major trial, multi-clinical trial done in the early 2000s. And it had three groups, just placebo, metformin, which is a medication, and then an intensive lifestyle group. And actually the lifestyle group was so successful, they ended up halting the trial early. And the results of that study found that a weight loss of 7 to 10% plus 150 minutes, a minimum of 150 minutes of moderate intensity aerobic activity or cardio decreased the risk of type 2 diabetes by 58%.
Wow.
And that was double of metformin. So highly successful, highly effective. The weight loss recommendation has since been decreased to at least 5%, just based on follow-up studies. So largely when we talk about prevention, it's going to be weight related as well as exercise, specifically aerobic activity. But we can definitely expand past that and look at some of the other factors. Like it's not just cardio. Resistance training is really important for at least maintaining or preserving muscle mass and increasing or upregulating GLUT4 protein, which allows that cellular uptake of glucose independent of insulin, helps to upregulate insulin receptors. So yeah, I'm a big fan of exercise.
Aren't we all in the
And
health community, right?
yeah. And then in terms of weight, there was an Indian diabetes prevention program, and actually looking at Chinese Americans and South Asians, weight was less of a predictive factor of diabetes risk compared to behavioral factors such as physical activity.
Interesting. Well, I want to put the other risk factors to the side. I kind of want to talk about the weight thing because, I've met people who have diabetes and they don't necessarily look very overweight. And, I've met people who are very overweight and they don't have diabetes. And so I guess is it always associated with body fat percentage, or is it like, so always associated with weight? I guess speak more to that.
Yeah. So most people with diabetes have overweight or obesity. And like I just said, with prediabetes and also for diabetes, the biggest emphasis in terms of prevention and treatment is going to be weight loss related. But not all individuals with diabetes have overweight or obesity. And like you said, not everybody who's overweight or obese then goes on to develop diabetes. So there's definitely some variation. A couple things that I think are important irrespective of weight would be visceral body fat. So visceral fat is the fat surrounding our organs that is more metabolically harmful. We also have subcutaneous fat, which is that kind of superficial layer. It's not metabolically harmful. So a greater percentage of visceral fat is associated or related to more insulin resistance in the body. And just looking at that, Asian Americans is found that they develop diabetes at a much lower BMI range than other ethnic groups. It's as low as 18.7. And keep in mind, the lower limit of a, quote, healthy BMI is 18.5. So Asian Americans actually develop it much earlier on in terms of weight. And that could be related to fat storage.
Do you think it has a correlation with like just their diet as to why maybe they have more visceral fat on their organs, or maybe is there a correlation as to why they get a pre-diabetic before other ethnicities?
I don't think it can be fully explained by the greater storage of visceral fat, but anytime we talk about any of these public health factors, again, we go down to like the complexity of genetics and gene environment interactions, lifestyle behaviors, maybe more sedentary behaviors, I don't know. I really don't think it's necessarily the diet, because if you look at various groups, everybody has their own version of lots of starch and saturated fats and low vegetable intake. Like every cultural diet kind of has their own version of that, I've realized. Interestingly, and this doesn't answer your question at all, but I think it's interesting.
Sure.
That Asian Americans have the highest rate of undiagnosed diabetes, I think it is. It's like 75% diabetes unawareness.
Wow.
I just thought that was interesting. And also, actually undiagnosed diabetes is around 30%, and then pre-diabetes unawareness was 75%. Again, most chronic diseases are this complex interaction between biology, lifestyle behaviors like sedentary lifestyle, maybe healthcare system barriers, access to food, access to resources, representation in healthcare, and then genetic propensity for some reason or another, and then gene environment interactions.
Changing people's behavior and for their diet to begin with is really difficult. And I guess are there kind of maybe clinical pearls that you've noticed that you found success with in changing people's dietary habits?
Yeah, so that's number one, is just really getting an understanding of somebody's goals, values, barriers, their readiness and willingness to change. I mean, no amount of information is going to help somebody change their diet if they're not there yet. So that's based on the trans-theoretical model of behavior change, aka stages of change. And that just really helps you to engage with the patient or with your client in a meaningful way, meet them where they are, and then tailor those recommendations or even the education based on, are they just learning about this disease? Is it a total shock to them? Do they have any experience with family members or friends? Or are they coming in hot and motivated, ready to make some changes? Those are going to be two different visits. And the way that you counsel, I think, makes a difference in terms of like kind of setting yourself or the patient up for the most success when they come back and see you, or even if they choose not to, because maybe you went in a little too hard with your recommendations. So that's one for sure. I find most people do better with the start low, go slow approach, as opposed to kind of jumping in and making drastic changes, which can kind of trigger rebound or burnout. So starting low, go slow, using those SMART goals. If you're familiar, like specific, measurable, attainable, realistic, time sensitive. And then motivational interviewing, going back to like the counseling techniques, I think has been really helpful. I'm not an expert, but some of the strategies being open-ended questions, affirmations, reflections, scaling is really useful as well. So scaling importance. How important is this to you on a scale from 1 to 10? Okay, it's a 6. What makes you rate it a 6 instead of a 3? Kind of understand, okay, how is this important to them? What would it take for it to be an 8? And then that can help in terms of like the education or the information that you're giving and the goals you're setting. And then rolling with resistance to change instead of kind of like going at it pretty strong. So for example, somebody might come in and say, you know, I don't want to change my diet. Okay.
Right.
Great. Let's say you don't make any changes to your diet. Tell me what your life looks like 5 years down the line. Just talk through it with them in a really open and kind of curious way. So I enjoy those strategies. I think it helps me to relate, engage, and empower patients, really allow them to take agency in the process of their change. Another one that's really helpful, I think, is continuous glucose monitoring, or CGM, which is a device that you wear, or patients wear, and it continuously measures blood sugar. So you kind of see this moving blood glucose pattern, and patients can directly engage with their personal data and see how do certain meals or foods or timings or portions or exercise or stress or sleep patterns influence their personal blood sugars. And then that's been showing up more also in the literature in terms of, yes, effect on A1C or blood sugar management, but in particular, behavior change.
Interesting, because it's almost like then they can learn their own body and like what responds to them, and they can kind of be like, okay, this food not going to work, but I can do this, and this is fine.
Yep, exactly.
And are you helping? You talked about goals, and one thing I find interesting and helpful for me is writing down goals. And I guess, do your clients or patients also write down their goals? Or are you kind of keeping like tracking them independently? I guess, how does that work?
Yeah. So after the visit, I write up a full summary for the patient with any of the useful information, resources, goals, strategies, and I send it to them. And it's just helpful for tracking. So I have it, they have it.
Now, do you ever dive into the side of medications? I know you had referenced some like medications against exercise in a study, and I guess how do you manage medication use when prescribing certain dietary recommendations? And are you recommending to talk to a doctor about certain medications?
Yeah. So I don't prescribe as a dietitian. That's just not something dietitians do, but I do talk to patients about medications. It's obviously an important part, or at least a large part of diabetes. So it's important that I know that and help kind of educate patients in terms of informed decision making. The ones that I see most often are metformin. So I mentioned that one before. It's often prescribed for prediabetes or polycystic ovarian syndrome, which is also another risk factor for diabetes in women. Don't really need to change too much in terms of the diet with metformin. There's no increased risk of hypoglycemia. The one area that I might counsel on is if they're having any GI effects. That's the main side effect of metformin is GI upset. Is to make sure to take it with food or switch to an extended release, which tends to have fewer side effects. And I guess kind of backing up from specific medications, I do think it's an important part of my job, and I see myself doing it more with type 2 diabetes, is taking a look at people's medications, their side effects, and is it really like the best therapy in terms of the evidence? If somebody, for example, is on oh man, it's a thiazolidine dione. which is kind of an older class of medication like glipizide or glyburide. And these promote insulin secretion, and they increase the risk of hypoglycemia and weight gain. They can increase edema or risk of congestive heart failure. I just don't really see them a lot. So if I see somebody coming in with that, I'll kind of advocate, oh, hey, did you know about these kind of newer, safer medications that don't have an increased effect on risk of low blood sugar or weight? So there's a little bit of advocacy going on there. Most of the patients that I work with now are not taking insulin. There are a handful. And so, of course, there's a conversation about how to match insulin to carbohydrates, how to use a corrective factor, that kind of thing. But largely the people I work with, they're taking metformin, which is super safe, very low side effects. And then the second agent that I see more of and that I tend to advocate more for is the GLP-1 receptor agonist. And so that class of medication is even edging out insulin as the second line medication. And studies have shown that that one lowers the risk of all-cause mortality, lowers the risk of cardiovascular disease. Yeah.
You know, it seems like you have a really good grasp on many different facets of like a patient's history and, you know, the things that are going on in their diet and their life that basically ultimately affects the way things are presenting for diabetes. And one question I had, I was wondering if you have the opportunity to like collaborate with other professions, whether maybe it's like trainers or PTs, OTs, speech pathology, to perhaps make sure there's a whole holistic approach to a certain patient, and maybe with prediabetes or diabetes.
Yeah, that's great. I'm a big fan of care coordination with other providers. And I have experience, even just from my first job many years ago, working in an intensive lifestyle change program with a psychologist, PhD psychologist, and a physical therapist. And then currently working with diabetes, we have myself as the, of course, diabetes educator. I focus more on blood sugar pattern management and nutrition and the diet. And we have a team of exercise physiologists who really take over the management and recommendations and strategies and problem solving related to exercise. And then we have primary care who will maintain medical management. And I do sometimes, again, advocate for certain types of medications, but they're very capable, they're very knowledgeable. So that takes that off of my plate, really. And then we have health coaches to kind of tie everything together. So in our program, the exercise physiologist, doctor, and myself, we meet with a patient with diabetes once every 3 months, unless we choose to do more frequently, and some patients need that. But in between, we have the health coach kind of continuing follow up on a more frequent basis to really focus on behavior change, focus on problem solving, and prioritizing and implementing all of those many recommendations for this complex chronic disease.
Well, it's got to be empowering for like from the patient perspective. I can imagine, like for myself, if I was going through that and I knew I had a team of people behind me trying to change my behavior, it would make me feel a lot better than feeling like I'm going through it alone.
That's the hope, is not to overwhelm them and to be there as a source of support and information and empowerment. So that's really what we're going for.
And we're kind of describing an ideal scenario, right? Like it's not always the case where you have all these people kind of in your corner. I guess paint maybe as a picture of somebody who may not be able to access all these resources. Are there ways to reach out to people who may be able to get you the help that you need, or is there something else perhaps out there that people can reference? I guess, what would you say?
Yeah, that one's really tough, and that goes down to like, in terms of who is at higher risk of not only the disease, but complications or the risk of death. That tends to be more historically marginalized populations. That's really tough, just having the resources, food access, representation in the health field. So I think that's an ongoing battle. Hopefully that person at least has a doctor, and that would be a good place to start in terms of getting a referral, asking what are the options for a dietitian or even certified diabetes care and education specialist. Let's say that's not available. Then there are resources that are free and available to people. Like if you need help with meal planning or recipes, going onto the diabetes food hub or something like that. But I think that one, like, unless you have access at least to your primary care doctor, then it's going to be really, really challenging.
And you're gonna have to want it, right? It's something that you like have to change. Like no one's gonna come knocking on your door and be like, "Hey, have you thought about your prediabetes and your high cholesterol recently?" And it's like, probably not.
Yeah, exactly. And I mean, there are often no signs and symptoms of prediabetes or diabetes. That usually happens for, of course, type 1 diabetes, or after years or decades of having diabetes. And so if you don't have symptoms and you feel fine, there aren't really resources. And we know that there's a high rate of undiagnosed prediabetes and diabetes. So that's very likely the case.
And you said no, there's no like there's sometimes there's like silent signs and symptoms for like prediabetes and diabetes. We mentioned that prediabetes is completely preventable, but is type 2 diabetes preventable at all, or like reversible whatsoever? Are there cases in where you got diagnosed with type 2 diabetes and you completely reversed it? And we know that type 1 diabetes cannot be reversed, just as a reference, because it's genetic. So for type 2, have you seen people that maybe have reversed course, or is it just more of just like a management thing from here on out?
Yeah, so I think it's becoming more and more clinically accepted to talk to patients about not necessarily reversal, and maybe it's just a semantic difference, but diabetes remission. It is not very common, but again, I think it's becoming more acceptable to start talking about it and start looking at those factors. There was a large study involving over 120,000 people, and 1.5% achieved remission. And remission is defined as blood sugar levels in a subdiabetic range without the use of medications or surgical intervention. So 1.5%. And that's not to say it couldn't be higher. We don't know, I don't know at least, what the resources were, what like the active push for helping people achieve remission was. But we know it's not very high, like as of now. But I do think that it is mechanistically possible, especially in the earlier stages of the diagnosis. So again, going back to that kind of progression, at a certain point, I am not sure that all cases of type 2 diabetes are reversible, but the earlier you are in that progression, you still have better beta cell function, lower insulin resistance, lower and maybe lower insulin levels, or maybe they're still high. It kind of varies. But at least looking at beta cell function and insulin resistance, we can impact those. People can impact those with changes. We know that in the earlier stages of the disease, the pancreatic beta cells that don't produce enough insulin aren't permanently damaged, and they can be restored to normal function primarily through the removal of excess fat storage. And then insulin resistance, that decreases with weight reduction, exercise, changes in the diet, stress management, improved sleep quality, all of those different things. So mechanistically, it's possible. It's just quite rare. I have personally seen some patients, a handful of patients achieve it, and they were diagnosed early. They were not started on medication. And that's not to say that medication itself obstructs the ability to achieve remission. It's just more of a marker of where somebody is in their progression of the disease.
Interesting. Well, I'm sure getting a diagnosis of diabetes and, feeling almost helpless where you're like, okay, if I have diabetes, there's no going back. You touched on stress management. I guess, how does stress affect diabetes, and does it make it more difficult to manage? Is it just a contributor to maybe, I was going to say reckless eating, but eating more than you should? How does stress management play in the role of diabetes?
Yeah, definitely. I mean, for both of those things, I mean, there's a physiological mechanism and there's also a behavioral component. And actually, the behavioral component is in part affected by the physiological changes. So with stress, chronic stress, elevated stress hormones such as cortisol, it's going to directly increase things like inflammation or insulin resistance. And even with continuous glucose monitoring, it's so interesting. I can see when somebody has had a stressful day or a stressful moment when blood sugars will just spike. And there also might be an actual release of sugars kind of mobilized in order for that fight or flight response. But the increase in those stress hormones elevates insulin resistance and inflammation. And so that's the physiological aspect that contributes to increase in diabetes risk. And then, like you said, that behavioral component as well. When we're really stressed, I mean, what do we tend to go for? Those comforting foods. There are two types of hunger: hedonic and homeostatic. Homeostatic is that just pure biological hunger to kind of sustain your life. Hedonic is that pleasure-based eating, but it is informed by hormones. So if we're really highly stressed, we tend to be more susceptible to that hedonic system, eating sugars and fats, and trigger those dopamine opioid receptors and get that kind of feeling better. So definitely a role for that as well.
And stress can certainly play a huge role in so many different things, but one aspect of it is perhaps even developing eating disorders. And I guess, is eating disorders within the realm of like having a diagnosis of diabetes common, or is it kind of like you have a disorder and then you get diabetes?
Yeah, I mean, I think a lot of things with diabetes that I can think of are bidirectional, so they can kind of contribute to one another. We certainly know that people with diabetes are at higher risk of eating disorder and disordered eating. And just clinically speaking, I've seen a lot more disordered eating than eating disorders. But it makes sense. I mean, people come in, they have a disease where they're told you need to lose weight. They're terrified of the complications of diabetes, maybe what it's done to family members. And automatically, what do people think? No more carbs, no more sugar. And so there's a lot of anxiety, there's a lot of disordered eating patterns, kind of compensatory mechanisms for dietary indiscretions, skipping meals, avoiding whole groups of food. And I don't know that there's a contribution of disordered eating to diabetes, but there's certainly more risk or more likelihood that someone with diabetes or prediabetes may display disordered eating. And the difference between eating disorder and disordered eating is just there's a diagnostic criteria for eating disorders, things like anorexia, bulimia, binge eating, relative energy deficiency in sport or something like that. So there's an actual diagnostic criteria, whereas disordered eating is just kind of a descriptive phrase. But it can be harmful in terms of quality of life, and that's actually a big piece of diabetes management. Is let's at least not do harm to somebody's quality of life in the pursuit of managing their blood sugars.
Yeah, I mean, do you have that rebound effect of like people sometimes when you tell them you have to lose weight and then they just go like to the extreme end and lose a significant amount of weight in a short period of time?
Oh, yeah, that's a good question. I don't think I've ever told somebody they need to lose weight, but looking back, I do definitely acknowledge that because I'm very upfront about what the evidence says, and weight loss is such a big part of that, that even just providing that information is going to spark that for somebody who's afraid to either develop diabetes or complications. So I have seen people really make drastic changes to their diets and really burn out. And I highly discourage against that. I'm very much about, I guess, promoting balance. And that's going to look different for everybody. But I'm especially coming from myself, a background of eating disorder, disordered eating. I definitely don't want to use language that encourages that in other people.
Well, I think that's amazing that you have that kind of, unfortunate that that happened to you, but now you have almost like this insight that no one, maybe no other nutritionist is going to be able to have. And you can empathize and you can say like, I've been there, or just, and you know how to, what to say. And that's so important. Language is so important. And was that hard for you when you first became a clinician and like learning what language to use and not to use?
I think for me, language has always been really important. I just am that way. I'm very pedantic and detail oriented, and words mean a lot. And actually, I think for me, it's been important to detach a little from language just for my own mental health. But I've always been very, very cognizant of that with other people. And there's always a bit of a learning curve because I hadn't been thrown in before with so many people. I've worked with hundreds of people now. And probably in the process, I have said things or maybe not said things that were ultimately damaging. And I totally acknowledge that, but I've always been very conscious of that.
Yeah, I know in my realm, one of the things I'm constantly dealing with is just pain and the, people's experience of pain, and the things that you say are so powerful. And the second someone comes I go to see them and, I say, well, you're weak and you have all this going on with you. It just creates more anxiety in that person's head. And it's just like, you're not being helpful. You need to be able to create empowerment. And I think what you're doing is amazing, and trying to use the right thing and being very short but concise and very effective in the way that you're presenting information, so that people can get the help that they need and become empowered, rather than being like, listen, you got to stop eating this food.
Yeah, I mean, ultimately, you don't have to do anything. It is a choice. Most people choose a path where they're going to protect their future health. Not everybody does. But I love what you said. Empowerment is so key. And really one of the drivers, I think, of motivation, above fear or duty even.
Yeah, why do I ask this question to a lot of people? It's just like, why are we so self-sabotaging? It's like, you can tell someone that these cigarettes are going to kill you in 5 years. Like we know this to a 95% of the time it's going to cause you damage, and yet people still go out and do it. And same thing with diabetes. And I guess, how do you manage with that, like the frustration overall with that, with like trying to change someone's behavior, so to speak?
Mm-hmm. I find it is very helpful to decouple from somebody else's behavior. I mean, that's not my role. I'm not here to necessarily change anybody. And so just even going in with the expectation that my role is to meet them where they are and where they want to be, no frustration. And that's not to say that I don't get sometimes emotionally involved because I care about these people. But again, going back to some of those counseling strategies, roll with resistance, use things that don't work and really explore that. And then often just change course in a way that feels empowering to them. I don't really like to dwell on those kinds of experiences or kind of imply that those were failures. And then focusing on what is it that they can do now, the joy of like what feels good to them. If what I am suggesting just isn't working, then really engaging them in that collaborative process.
Well, I love that you're able to kind of look at a 10,000-foot view and not overanalyze and kind of separate yourself. I know for me, when I was doing a couple clinical rotations as a PT working in the hospital, at first I was like, I need to create this barrier between me and my patient. Cause again, you get involved emotionally and you care so much. And it's like, you care, but then it's like, you got to go into the next room, you got to see another patient, or for you're seeing another client. And so you can't carry that with you. And I think that's, at least I've had to develop that. And I'm not sure if that's something that you've developed over time as well.
Again, I think it's just something that somehow comes intrinsically or is kind of innate, where I don't necessarily bring it back with me, or I don't necessarily feel like their success is tied to my success as a dietitian. And maybe that's because I've gone through such a roller coaster in my own life, and I acknowledge like all these people are trying to help me, like there's nothing wrong with what they're doing, but there's a level of perhaps codependency in healthcare, and luckily it's just not something that I've ever really had to deal with, but I totally get it. Like we care, so we're more likely to feel emotionally attached to the outcomes of the people we're working with. So it is tough, and I think to a certain extent I get that subconsciously or unconsciously, but it's not something that's at the forefront of my mind, like, why am I not getting through to this patient, or what am I doing wrong? It's just, again, curiosity, growth mindset, is acknowledging everybody's at a different stage in their journey, and I'm just here to support wherever they are, however they need, outcomes aside.
And I'm sure your patients really appreciate your ability to be process oriented and be able to identify what needs to be done and help them along their journey. And well, believe it or not, we've already gotten up to an hour, which is amazing, and flew by. And we're kind of closing in on this last portion of the podcast, which is called the Health Me to Health You. And I gave the questions to you prior to kind of look over. And the first question I asked everybody at the end is, if you had the attention of everyone in the world for 30 seconds, what would you say?
I want to do the annoying thing where you ask, like, if you had one wish, what would you wish for? And you're like, 3 more wishes.
Right, exactly. Yeah. More time.
But okay, if I can't do that, this one's really tough because my mind goes into dozens of different directions. So if I were to just kind of choose a direction, and let's say I have 30 seconds to talk about like nutrition, because I'm a dietitian, might as well focus on that.
Sure.
I would say I think it's important that we start focusing on what we agree on when it comes to nutrition, and instead of promoting more divisive messages or nutrition dogma or the latest sensationalized headline or fad diet, and really acknowledge that we are all, again, unique in terms of the composition of genetics, epigenetics, microbiome, environment, environmental exposures, gene environment interaction. And therefore, there really truly can't be a best diet. And what we can agree on, I think, and these are actually 3 things that really come in a lot when I counsel for prediabetes and diabetes. It comes from the Nutrition Consensus Report for prediabetes and type 2 diabetes, would be primarily, actually, if I were to just choose one, would be emphasizing more whole foods or minimally processed foods over highly processed foods to the extent possible. And then the other 2 would be emphasizing non-starchy vegetables and limiting added sugars and refined carbohydrates. And I'm pretty sure that's incontrovertible, but we'll see.
It's always changing in the field of nutrition and everything. So we'll be sure to see, and I'm sure that'll be helpful for a lot of people who may have questions about it. Second question, what book do you recommend, whether a book you're reading now or in the past or both?
Yes. So immediately I thought of The Omnivore's Dilemma by Michael Pollan. I read that book maybe 4 times in college, so once a year. And it's really what got me into nutrition. And again, from more of a global perspective. So Michael Pollan is an investigative journalist out of Berkeley, and he sought to answer an ostensibly simple question of what should we have for dinner? And he kind of walks through everything, getting that meal to your plate and all the things we don't really consider in terms of the food system dynamics and politics and environment and the human factor. So I just think that's a great book. And I think arguably the most iconic 7 words of any of his writing that still resonate with me more than 10 years later are eat food, not too much, mostly plants.
Well, I'm gonna have to go read that book then, because I haven't. Very motivational. Third question: where can more people learn about you, and then also about diabetes if they're curious?
Yeah, I don't have a very large social media presence, but I am on LinkedIn, so that would be the one place where people can find me. And then for providers or practitioners to learn more about diabetes and guidelines and best practice, I recommend looking into the American Diabetes Association Standards of Care for Diabetes. It's updated every year. And there's also the AACE Executive Summary, and that was last updated in 2020. There's Diabetes Education Services, which was created by Beverly Tomassian. She's a registered nurse and a CDCES. She takes the exam every 5 years. So she chooses to continue taking the exam. She has some amazing resources, mostly, again, I think for providers or practitioners. She has medication pocket cards that I think are great. Online courses, conferences, a blog. So her website is diabetesed.net. And then resources for patients would be the diabetesfoodhub.org for recipes and meal planning. And then Diabetes Educators has a good online diabetes resource center.
Alicia, thank you so much for coming on the podcast. This is great.
Thank you so much for having me.
No problem.